Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much, Doctora, and would like to thank the organizing committee for giving me this opportunity to be with you this afternoon to talk about a dear topic to my heart. I have nothing to disclose. My interest in pain, pediatric pain management started in the late 90s. I was trained in Dalhousie University with pediatric anesthesiologist, Prof. Alan Finley, who is with the pediatric psychologist, Prof. Patrick McGrath, started some of the early studies about pediatric pain assessment and management. When I came back to King Faisal in Riyadh, significant proportion of our patients in the perioperative pain was among the pediatric age group. What makes it even more interesting that I was asked to participate in the project of intrauterine fetal surgery from the anesthesia and pain point of view. We have come across a long way since that time. Now we have a dedicated pediatric pain management fellowship. We probably have the most significant advancement in pain medicine over the last 30 or 40 years is the mechanism-based pain classifications, which is basically classify pain to two types, major types. The psychogenic pain is actually diagnosed by exclusion, but the two main types is the neuropathic and the nociceptive. When you told me this patient had a neuropathic pain, I would have the descriptive of pain of these patients. That's usually burning type of pain, electrical shooting pain with pins and needles, probably with have allodynia or hyperalgesia on the examinations. So it's have a descriptive value in addition to the prescriptive value. So it will guide our treatment. Again, if you told me this patient would have a neuropathic pain, probably they need to have anti-neuropathic pain medications, whether it is cyclic antidepressant, SSRI or SNRI, or gabapentinoids. But it also have a predictive value. So with neuropathic pain, usually there is a neuroplasticity happened either in the peripheral or the central nervous system, which make the chronicity of the pain is more chances in these patients. By the same time, probably one of the most challenges in pain medicine continue to be the pain assessment. There is multiple barriers to adequate pain assessment. Time, lack of time from us as clinicians is probably the biggest, but also lack of trainer, and even more important, the tools. We don't have any objective tools that actually sensitive and specific enough to tell me this patient had pain or not, rather than to have the intensity of the pain. Most of us will depend on the subjective tools, and it is usually unidimensional, which means only one dimension of pain, which is the pain intensity. But we know, all of us knows that pain experience is actually multifactorial. In addition to the biological factors contributing to the pain, the psychological aspect is very important, like belief of patients about the pain, attitudes and thoughts of patients, and the previous painful experience, in addition even to the belief and the cultural beliefs about the pain and the dynamics within the family. This has shown not only to affect the pain perceptions, intensity of the pain, but also the response to the treatment. So the comprehensive assessment of pain is recommended, and it should also include the consequences of pain, because functional status that was limited by the pain in the pediatric age group, or the psychological aspect, or the social impact, can be used as a monitor for the success of our treatment, as one of the monitors to monitor treatment in these patients. The multidimensional instrument or tools is recommended to have more holistic understanding of the child pain, and there is more than 40 tools that has been validated in pediatric age group. Of course, when you hear 40, that means there's no single standard, gold standard tools. And the reason for that, because there is no single tools that can cover all these aspects. So some of these will be focusing on the psychological aspects, like the pediatric pain catastrophizing scale, which evaluate mainly the child-related thought and emotions. Others is disease-specific, like the juvenile arthritis disease activity scores. But having a holistic understanding of the child pain would probably have a more opportunity to tailor the management, long-term management for these patients. Again, the aspect of the culture and language, assuming these tools is valid in our part of the world, should be validated. And a group of King Faisal in Riyadh, they worked on the translating and validating these common tools, questionnaire tools that used in adult patients. But in pediatric, I think the opportunity is still there. Most of the pediatric questionnaires that is Arabic translated and validated is the single or unidimensional tools. So the multi-dimensional tools need to be translated and validated in our part of the world. Some of these tools is used to predict or to detect whether the pain have neuropathic component or mainly nociceptive component. The technology, or advancement technology, widened our options in these tools. So in addition to the paper-based tools, we have also now the web-based pediatric pain assessment tools. In addition, also we have the mobile apps which can be used and utilized for assessing pain in pediatric age group. Super Kids, for instance, is one of the examples that have been specifically developed for pediatric rheumatology clinics. And depending on the age of the patients, if it is 8 or younger, the parent or the caregiver usually will fill some of these questions. Some of these questionnaires which has been studied is licensed for business, and others have the feature to trigger the clinicians to, or the alarm to the clinician that he need to intervene when the threshold reach in pain follow-up with the pain patients. Among the mobile tools that are available currently, there is 2 types. The type is publicly available, which is usually not studied in research, usually have no involvement of the stakeholders, whether the patients or the clinicians. And the others is the studied on research, but unfortunately not publicly available. One example is the My Pain Tracker that has been evidence-based e-health designed for specifically also for patients with pediatric rheumatic disease. It is user-friendly, so it's used to drag and drop the on the pain area, and it have some symbols to indicate the type of or quality of pain and the intensity. And it also have the clinician's interface, which plotted in a diagrammatic view that help us to monitor the pain over time. In one systematic review of the available, publicly available apps, the security and the patient privacy is a concern. Also, a lot of these apps will disappear, like we don't find it in 1 or 2 years. So the transiency is another problem in these apps. Hopefully with the development of the artificial intelligence and the using facial recognitions, in addition to the data that can be collected from the wearable, including the stress level, the physical activity, sleep pattern, more evaluations, or more objective evaluations of the pain in this group of patients can be achieved. So the management, of course, will depend on the, I spend sometimes on the evaluation because our management actually will be guided by the evaluations. If it is an acute, usually it's few days we expected, or sometimes weeks, that the pain will be subsided. Usually this pain with responses to the simple analgesics, acetaminophen, non-steroidal anti-inflammatory drugs, and depend on the severity, opioid might be needed. Chronic is usually defined by duration of more than 3 months. If the pain is more than 3 months, this is a chronic pain. Now we are talking about the transitional pain, which is the period between the pain which is expected to finish, for instance, a post-operative pain that has been, or post-inflammations that's supposed to be relieved within 2 or 3 days, but still continuing for a week or so. This is where probably the neuroplasticity happening, so the chances to prevent chronicity of the pain is in this period. That's we need to target the transitional pain, and you will see in the future probably a lot of publications about transitional pain. So we have the chronic pain, acute pain, and transitional pain. Nociceptive is the normal pain that's due to inflammations, surgery, procedures, and compared to the neuropathic pain, which is usually malfunction of the nervous system, whether it's peripheral or central. And most in real life, there is a lot of studies even for the inflammatory shoulder disease. There is a 28% of patients with inflammatory shoulder disease have neuropathic pain component. And the significance of that is to be able to control pain, we need to address this aspect as well. The best treatment of pain, of course, is to treat the underlying cause if possible. Sometimes that's not feasible. So the symptomatic treatment would be the alternative. Depending on our evaluations, the this is here. The biopsychological social model of pain, depending on which, in our evaluation, which component have bigger magnitude would direct our management. So for instance, in patients who had psychological aspect is significant, or social aspect is significant, we need to focus more on this in our management. So the non-pharmacological would include the physical therapy, the cognitive behavioral therapy, in addition to the TENS machines and other like acupunctures. The pharmacological aspect, as for us as a physician, is the main modalities that we are good at. But again, if the psychological assessment and the social assessment is done properly, we need to treat these as well. Regarding the interventional pain management in pediatric, we have two targets, either targeting the pain generator, which could be the joints, the muscles, or the tendons, or the blood, the nerve supply, the sensory nerve supply that getting the innervations from these structures. And we have the ability to ablate this nerve supply if there is no motor component, or like the genicular nerve for the knee or the shoulder. Now we have also we can completely denervate the shoulder joints. And also we have the ability to neuromodulate with the neuromodulators to modulate without ablation, just to modulate the nerve supply to these structures. Surgical is rarely used in pain management, but it could be used in certain conditions. And based on the available resources and the response to treatment, individual or personalized pain management plan for this, of course, need to be reevaluated and monitored with time. I will shift gear now with the most frustrating outcome probably to us in pain medicine, and also I'm sure for you in rheumatology, is the what we used to call widespread pain that include fibromyalgia, the temporomandibular joint disorder, chronic pelvic pain syndromes, irritable bowel syndromes. Now it's a group together, we call them chronic overlapping pain conditions. They are, as you know, and see in real life, they are very common, usually happen or more common in adolescent females. And usually most of these patients would have 2 or 3 overlapping in the same time. The psychological, biological, psychological, social model is the can explain why these patients have these conditions. Probably the baseline psychological conditions, the previous response to painful experience, environmental support. We shouldn't be distracted by incidental findings in these patients. I remember one young patient who had mild scoliosis, who has been advised by the neurospine surgeon to avoid surgery, but he was insisting, and he went to Germany actually, and he had his surgery. They did a complete instrumentation of his spine. He came back with worse pain. They had to remove the instrument, and now, unfortunately, he's crippled on multiple narcotics. Another example is a lady who was actually a medical student in her adolescent. She had diagnosis of chronic the complex regional pain syndrome in one of her hands that has spinal cord stimulators. Then this migrated to the other limbs, so have another spinal cord stimulators. Unfortunately, even her head's abdomen and chest is all spread the painful area. Of course, she had irritable bowel syndrome, she had migraine headache, so she had typical chronic overlapping pain syndromes. But treating, or our way of treating these patients was unfortunately not the right way, as we'll talk about it in a few slides. The epigenetics probably plays an important role, which is the change of our genes, expressions of pain, depending on our behaviors and environments. This is luckily reversible. It doesn't change the DNA sequence, but it changes how our body responds to pain. The early childhood could be an important factors or predisposing factors, the microbiome, and there might be also a triggering factors like an illness or trauma, whether it is physical or psychological. Associated usually in a personality which is catastrophizing, they focus only on pain. They have the belief that there is nothing, the pain will get worse with time. Also, they have the belief that there is nothing will help them. And in a passive coping strategy, they relying on others to take care of their pain and their life. And also maladaptive coping, they usually will tend to withdraw and avoid facing their problems. And usually there might be some also peripheral or central sensitizations of the nervous system that also make the pain is worse than their counterparts. So the goal of treatment in this group of patients is focus on function. We need to get them back to schools in this age group, we could use all others available modalities of treatment to help this goal. So whether it is the physical therapy is the major focus for this age group, for this treatment, but the cognitive behavioral therapy can help to change their mindset, to help to improve the coping skills in these patients. The goals also need to limit the secondary gains. These patients sometimes have secondary gains, might be abstinence from schools, for instance. That could be a secondary gains that would have the role of sick rules in this pediatric age group more concentrated, so they will complain of pain and they try to omit schools. Also, there might be parent attention that can be a secondary gain. So, or sometimes even worse, it could be narcotic or controlled medications, the effect of this as a secondary gain from the being sick or being in pain. They tend to have 3 phases. The first phase, which is usually they refuse the bio-behavioral psychological model, and they will probably not accept to go for psychological or cognitive behavioral therapy. Our role will be depending on the stage. So in this stage, probably we should have limited educations. We should give them distance appointments, because really there is nothing much we can offer if they don't accept the cognitive behavioral therapy. And as I mentioned, probably you will see these patients insisting to come, and the intervention sometimes is worse than the disease itself. Some disease patient can go for surgery for non-specific back pain or being in narcotic, which become a second problem rather than pain. Also, they will have drug dependence disorder. So in this stage, our roles is mainly mild educations, which we shouldn't be confrontational with these patients or their family. Once they accept, with time, they will see there is nothing help their pain, whether it's the medications, the interventions. Some of them, they will think about accepting the cognitive behavioral therapy or the psychological therapy. Once they have the action plan or action stage, then our role will be to coach and mentor them. The only treatment that have curative in fibromyalgia or in these groups in general is physical therapy. So there is a hope that these patients can be cured if they have acceptance to the cognitive biopsychological behavioral approach. To help them, of course, in the beginning, it will be painful to do exercises, but that can be helped by pharmacological and also the cognitive behavioral therapy during this stage. Once they have back to their activities, which should be gradual basing, so starting with minor activity that's increased on specific duration. The opioid has been shown to have no roles in this group of patients. Actually, it could have the opposite. It can, it is inefficient, but it could be harmful. So it should be really not offered to this group of patients. The other medications, like the acetaminophen or the non-steroidal anti-inflammatory drugs, the antidepressant, can be offered, but usually for short periods, And the main goal is to help the physical therapy to avoid or to overcome the avoidance fear. Because most of these patients in the beginning, they fear exercise because of the fear of pain itself. So they avoided exercise to avoid pain. But once this is broken, hopefully they will go to the other, to the next level. Topical is attractive in this, among this group of patients, like lidocaine patch or lidocaine gel, paracetamol, non-steroidals, again, probably either topical or the Cochrane analysis has failed to show either efficacy or harm in this. So if we need it, it should be for short period for this group of patients. The SSRI and SNRI, again, it should be used for specific tasks to improve, for instance, sleep or mood, and it should be for short period. Gabapentinoids, because it's a controlled medications, also the habituations can be a problem, so I think it should be avoided in this group. What will help also to have a therapeutic alliance with the patient family and the other team members like the physical therapist, the cognitive behavioral therapist. It's important also not to focus only on the child, but also on the parents and on the in the household, because some of the family focusing on the pain issues in the patients, and it's better to refocus or redirect the focus on the function. So instead of asking about the pain, they should ask about how the improvement in her function. Resilience home caregiver has shown to have better success and outcome, and vice versa also is true. So the best known method to address chronic pain conditions that is really vague etiology is to have the multifaceted approach, like the covering the social, psychological, biological, behavioral, and that will be probably different from patient to patient. Some of these patients might have problems within the family or the social issues. Other psychological might be more, or others might be an issue with the hypersensitivities or central sensitivity. Biobehavioral has shown the impact of the biobehavioral in this group of patients is better than pharmacological intervention. It's important not to focus because there's be a morbid conditions like the orthostatic hypotension. I know this patient, for instance, she had pacemaker, so focusing also on these cardiac symptoms might undermine and delay the treatment of the chronic overlapping pain conditions in these patients. So we should address these comorbidities, but without focusing on them, because we don't want to have the sick role in these patients exaggerated. So we need to focus or shift their focus on their how to cope better in life, how to have vision for the next year, in breaking the cycles of focusing only on pain, and pain will get worse, and there is nothing will help to control the pain. Unfortunately, there's some of the complications from this disorder is inflicted by us. For instance, in a survey in United States, more than 25,000 chronic pain patients, 20% has been put on opioids in this age group, which of course this could destroy their whole life. Again, technology is one of the promising tools that can be used, because I know there is availability of cognitive behavioral therapists or psychologists is not available in all of our hospitals. So the offering the initial apps that can be used to, like the teen, one of the, was an example is Teen Taking Charge, that is evidence-based cognitive behavioral strategy for pain, which have input from the family, from the clinicians, showed improvement in pain and pain interference in youth with juvenile idiopathic arthritis, as in this study. The web-based also, again, there is a web-based and there is an apps that's available to help with the pain educations as well as the cognitive behavioral therapy. And that's probably, I don't know what time is okay, time?
1 minute.
So I think there is a lot of materials and tools in the technology that can be helpful in this management of these difficult group of patients. One of them is like the extended reality, and that can be used to remapping the painful area in the brain. In conclusion, pain assessment is the cornerstone for managing is the cornerstone to construct individual pain management plan for pain and rheumatic disease. The biopsychosocial pain model should be the basis for assessment and management. Treating the underlying rheumatological disease is the preferred pain management whenever is possible and feasible. The patient caregiver and available resources should be considered when we construct the plan for the individual patients, and the multimodal approach, including the physical therapist, the occupational therapist, and cognitive behavioral therapy. And the technology hopefully will help us in the future to manage better these patients. Thank you.
Thank you, Dr. Abdullah, for this excellent overview of the pain and the possible causes and management. So the floor is open now for questions.
I can hear you, sir. I think I can hear. We can't hear your voice. I think it's clear.
Thank you. Thank you for that excellent talk. And I don't have a question, but just I was inclined to make a comment. When I practice in UK, 75% of my patients in the clinic, they have got generalized pain. And the background is quite similar to how you described, the social factors, the belief which they have, and including some are looking for secondary gains, including taking benefits from the system. But one thing which we have noticed has worked a lot is doing a multidisciplinary clinics. So in the same clinic, we have got a rheumatologist, a physiotherapist, and occupational therapist. Because what we have noticed is sometimes these patients and parents, they do shopping among professionals. So if they don't get a satisfactory answer from one professional, they might try to look for the answer in a different professional. So now we conduct the clinic together, tackling the questions all together, having a thorough assessment, whatever investigations, if at all. But most of the patients which they benefit from is physiotherapy. And we try to avoid labeling them with fibromyalgia. We try to avoid any hypermobile EDS and things. We just call generalized pain. And try to avoid medicine and just physiotherapy, and that seems to work much better than seeing them individual clinics and prescribing medicine. So thank you very much for sharing your lecture. Thank you.
Thank you, Dr. Abdullah. Great talk and sensitive area to be touched as we are suffering from those and with those type of patients. I have two questions. First one, when would you recommend us to refer our patient to pain management clinic? The second question, you mentioned the NSAIDs might benefit for short time, SSRI as well. What's your definition of this short period? Is that the 3 months that you mentioned that for brain elasticity, that when we should tackle the pain before it move to the kind of transition chronic type of pain? Thank you.
Thank you so much, Doctora. Regarding the first questions about the pain clinic, our roles is really mainly interventional pain management. So we used to be focused on narcotic, but you know about the epidemics of narcotic in the States, and I think we are lucky in the kingdom. We have strict rules, so we are safe from that problems and that issues. For pain clinic, if patients need interventional, I think he will benefit from referral. Otherwise, most of the medications you can prescribe it. I don't think there is a major role for us in the pain clinic. The other questions is about the short. I think the best approach for is to have a goal guided, like we'll give you this medications to help you to do this activities, but not for just to give it for pain, because pain probably would be there, and he will have, most of these patients will pass in these stages at different levels. Like they will not have, they will reach to action and they will continue. Some of them might relapse and go to the pre-contemplative stage. So it's our rules is really to just coach them, to monitor them, and if they need these medications for specific goals, for instance, for depression if they are depressed, or for sleep disturbance, for pain control, to make them able to have better compliant with the physical therapist, for instance.
I have a question. Is the acupuncture for children available here in the kingdom for pain management?
We used to have it in King Faisal, but the rules of acupuncture is mainly for musculoskeletal pain, and usually the studies had shown it's short-lived, the effect. It's like the physical therapy. It will help for instance, within the period. I'm not sure if it is available in the kingdom, but I saw the Al-Hijn, you know, the Al-Hijn, in our hospital, John Hopkins.
For children,
I'm not sure, maybe Dr. Anizi. For adults, we don't have it in John Hopkins also.
Okay. Do you prefer to admit the patient for management of pain, or as you treat as outpatient?
Again, that's we try to avoid sick role for these patients. Some of them, they would prefer to go to the hospital and have, but I think we should encourage the positive coping strategies. So most of our procedure now is done as an outpatient, even the spinal cord stimulators. But the admission sometimes actually would worsen the conditions rather than, because that will stress the sick roles in these patients. So we try to really encourage better coping strategies within the family. Even sometimes the parent will ask for admissions or for medications. So sometimes the cognitive behavioral therapy should be targeted also to the family or to the parents.
Okay.
Thank you for the talk. What is the role for like assessment of like, for example, like small fiber like disease and like doing like a little bit like more investigation to figure out if they have like a neurological issue or like neuropathy for these like patients with chronic pain?
This is an important aspect because these patients have genuine pain. We should stress that we understand they have genuine pain, but unfortunately we don't have the solutions. Our interventions would be probably worse. Sometimes if you are worried about differential diagnosis, we can do investigations, but again, the patient need to understand that we don't have the magic solutions. The best approach to stress the physical therapy and also the acceptance of cognitive behavioral therapy, because as in England, I think the problem here in Saudi Arabia, some of these will show up in different hospitals, and even they will go outside the kingdom to look for somebody who will give them the treatment. So I think education is important. We shouldn't get in confrontational with these patients. Eventually, they will be convinced once they try some of these modalities. But there is really sad stories for these young patients who really haven't been guided by us in the medical field to the physical therapy, occupational therapy, because for patients, for instance, non-specific back pain, they might go to different colleague, and some of them for probably secondary gains, they might do surgeries, and that will create even failed back surgery syndrome, which is even worse than their non-specific back pain. So I agree that probably investigation can be done to assure the patient and assure also ourselves there is nothing is missing, but also patient has to understand that we probably shouldn't focus on these incidental findings. That I always tell my patients, if we do MRI for 100 normal patient who is not complaining of back pain, studies has shown 66% will have abnormal MRI. So if we're treating all these abnormal MRI, that will have really bad consequences. So we should treat the patient's pain rather than the investigational or incidental findings in some of these investigations.
So I think we will conclude this session with many thanks to Dr. Abdullah.